As promised, we'll now try and give you the essential information to help you decide whether or not to proceed with a knee replacement. We will explain what a knee replacement is, what it involves, and what the potential outcomes are following the surgery. We'll be outlining questions such as, can I get back to sport and what kind of sport? Will I be totally pain-free? Will it feel like a normal knee? Will I be able to walk normally? Will I be able to kneel? Will I be able to go up and down the stairs without having to hold on? Will I be able to walk normally and unlimited distances? Will I continue to have any discomfort at night? How long will it take me to be off my crutches? When can I expect to be functioning normally again? The first thing I'd like to do is talk about how successful is a knee replacement. What can I expect in terms of my overall result? And I like to refer people to what I call the happiness curve. And I think the best way of demonstrating this is by putting it onto a graph. So we've got three very distinct groups following knee replacement surgery. We've got the very happy patients, and they're perhaps 10%. We've got patients that are glad they had the surgery, they'd recommend it to a friend, they would have the surgery again. And they're approximately 75 to 80% of the people undergoing the surgery. Having said that, they're not 100% happy because the knee clicks a bit, it swells a bit, it feels a little stiff, they find it a struggle to bend and kneel. They'd like to be able to play their sports and be as active as they were prior to the surgery, but they can't. But the really important thing is their pain has dropped considerably, from 10 out of 10, where they can't sleep at night or function or walk even short distances, and they can do those things. Their pain drops from maybe 10 to maybe 2 out of 10 on a visual analog scale. So they still have some slight discomfort, but it's significantly better than it was prior to the surgery. Their knee used to keep them awake at night, but they no longer have that problem. They can sleep through the night. They used to go up and down the stairs on all fours, literally, because the knee was so stiff and painful. And now they can go up and down the stairs, but perhaps have to hold on very slightly. And then we have the failure group. And this is probably somewhere between 10 and 15%. And these are people that are much worse off than they were prior to the surgery being undertaken. Now of those, of the whole 100% of patients that we look at, perhaps 2% have a problem. They have an infection, they have a blood clot in the calf or the lungs, some sort of anaesthetic complication. Something's wrong with the way the components are aligned. The surgeon's not happy with the outcome of his surgery. And that happens to perhaps 2% of people. And where that's the case, we can normally sort that out by doing further surgery. But unfortunately, it leaves 10, maybe 12% of people who have the surgery and they're much worse off than before they started. So you need to really be in a position where your pain is bad enough that you would take a 10 to 12% risk of being significantly worse off following the surgery than you were prior to the surgery. So if you're that person that literally can't walk anywhere, you're constantly in discomfort, you're having to use a stick to get around, your knee is literally driving you crazy, obviously it's a no-brainer. This is a great operation, and we do perhaps 100,000 knee replacements in the UK each year, and worldwide literally 1 million knee replacements are taking place. And this operation wouldn't be done on that kind of scale unless it was very successful. But there are these three distinct groups. Now I just want to finish off the success story by talking about hip replacements, which is completely different, and you can't compare the two. With a hip replacement, the success rate, the patients that are absolutely delighted, goes from 10%, which is what we see with the knee replacement patients, to as high as 90%. And that's because replacing a hip is a much more straightforward thing to do in terms of the geometry of the joint. It's a simple ball and socket. And replacing it really does reproduce totally normal function in the vast majority of patients. And that's why it has such a high quality of life improvement. But for knee replacement surgery, it's different. It's a very complex joint. It doesn't just act as a hinge, it also rotates. It's a very superficial joint, and it doesn't behave in the same way as a replaced hip replacement does. So I'd like to focus now on a few of the outcomes that we can talk about following knee replacement surgery. How will I improve? How will I change? Let's talk about pain first, because that is the single most important reason for undertaking a total knee replacement. As your joint becomes arthritic and the bone starts to grind into the bone, or even prior to that when you have significant joint surface damage and you have loose flaps of articular cartilage breaking away within the knee, that can obviously cause a lot of pain. And the pain typically is there during the day and limits the ability of a patient to walk, to climb a flight of stairs, to sleep at night, or to do anything particularly physical. The best way we can measure that is by asking patients to quantify it. And although it's subjective, be as objective as they can. And we use what we call the visual analog scale, and this is from 0 to 10. 10 is the worst pain you can imagine, 0 is no pain at all. And we're all different. Now if your pain is 8, 9 out of 10, and it's there most of the time, then it may well be, if you have an arthritic knee, that you should be thinking about knee replacement surgery. If, however, your knee's bothering you, it troubles you, but it's manageable, it's more like 5 or 6 out of 10, you can still play 9 holes of golf, and you're reasonably happy with that. You can go for a walk, it just aches a bit afterwards. You can go up and down stairs relatively normally, perhaps a little bit slower, and you haven't tried painkillers on a regular basis, then it is not the right time for you to consider a knee replacement. It really needs to be when the pain is interfering with life on a very regular and constant basis. So then what can we do with that pain? Well, if you're lucky, all the pain will go following a knee replacement. And that happens in perhaps 10% of patients. But most patients still have some discomfort. And when you say you're happy with your knee replacement, often they're not, because they'd like to be pain-free and they'd like to have a new knee. What we're doing is a relative simplification of what is a very complex structure. And although the knee replacement functions relatively well, so most people continue to have some discomfort and they would like to have no pain. So they're not 100% happy that they still have some discomfort. So with regards to pain, your pain is highly likely to improve. It may even disappear completely, but it is more than likely that you will have some discomfort afterwards, but it will be significantly better. But do not consider knee replacement surgery until your pain is really quite severe and you've tried to deal with that by adopting simple measures such as taking regular painkillers and anti-inflammatory tablets. So now looking at the non-operative measures that you can consider before you go down the knee replacement route is the use of a stick. By using a stick away from the affected side, so if you have an arthritic right knee, you hold the stick in your left hand, it offloads the joint. Losing weight, although this is very difficult, will definitely help you to reduce your pain. You need to have a very serious discussion with your GP about what painkillers are available, because there are lots of very complex and very clever drugs now that you can take both during the day and at night to try and help manage your pain. If you have a knee replacement, you would like to have normal function, and as I've previously mentioned, it's unlikely that it will feel completely normal. Now it may be that you'll be able to walk as far as you like and over rough ground without any issues at all, but again the chance of that happening is probably only about 10%. Most people have a limit to which they're comfortable walking following a knee replacement. We would hope that you'd be able to walk around a golf course, and most people can do that, but it is also relatively likely that by the 15th, 16th hole the knee may be playing you up again. So for some people they can manage 20 to 30 minutes, but again they still need to take a break because their knee is aching following a knee replacement. Will it feel like a normal knee? When we carry out the knee replacement procedure, most of the time we have to remove a lot of the soft tissue structures that are important for the knee to behave normally. That is essentially the cruciate ligaments in the middle of the knee. These get removed routinely as part of the knee replacement to allow us to put the new knee in. Without those very important ligaments, the knee feels and behaves differently with the artificial joint as opposed to the native joint. We're doing our best at the moment to try and come up with new techniques for doing knee replacement surgery where we preserve these ligaments, and these will come online over the next 5 to 10 years, I'm sure. But at present, without those ligaments, it's highly likely that your knee won't feel normal. It's likely to click, and you'll get a sensation of clicking as the plastic and the metal touch. That's completely normal, and as long as your surgeon has mentioned this to you, it won't worry you. The knee won't feel 100% stable, so it just feels a little unstable, not as though it's going to give way, but just not like a normal knee. That happens in a significant proportion of patients. Most people now can fully straighten their knee, and they can bend their knee up behind them to a very great extent. Before we were happy with a right angle, so going from straight to 90 degrees, and 10 years ago that was considered to be a very reasonable amount of movement to have following an artificial knee. Now we've improved, now we can get the knee much further, perhaps not as much as a normal knee, but we can certainly improve the range of movement. And in fact, one of the main determinations of how well the knee will move after surgery is how well your knee moves before surgery. And just to finally finish on stability, A lot of patients have the sensation that their knee is going to let them down and give way before they have the procedure. Often patients have a major problem with instability prior to their knee replacement. Their knee feels very unstable, and that's because it hurts, and those pain signals switch off the muscles around the knee as a safety measure, and the brain is saying there's something wrong, and the knee feels or does indeed give way. Following the knee replacement surgery, your knee is likely to feel much more stable, but it may still feel slightly unstable because it's not a normal knee. So let's talk about night pain. A lot of people, in fact, one of the main indications for knee replacement surgery is pain that keeps you awake at night. And frequently people will wake many times throughout the night, or perhaps get very little sleep because their knee is hurting. Following your knee replacement, it is likely that you will be able to sleep throughout the night without waking due to pain. In terms of getting over the procedure, the first few weeks are quite uncomfortable. You have the surgery. When you wake up, your knee is covered in bandages which are taken down the very next day, and we get you up and going with the physios very quickly. You're not allowed to leave until you're safe. So that means that you can walk with your crutches, you can go up and down a flight of stairs, you can manage to get to the loo. So people really can be quite independent. With modern techniques, we've been able to get patients up and out of hospital 3 to 4 days after their surgery, whereas not that long ago, patients were frequently staying in for more than a week. Once you're at home, there is a fair amount of discomfort, but this is well managed with the pain relief that you'll be given by your doctors. And you take this pain relief during the day and at night to help you sleep. By the 6th week, the exercises that you've been doing will have made the knee strong enough for you to begin to really enjoy your knee, and you'll be able to get out, start driving, and start thinking about being more active, going to the shops and living life in a normal fashion. So by 6 weeks, things have improved. By 3 months, the knee is really beginning to settle down. In some people it takes longer, and you have to give it 6 months before you have an idea as to whether or not it's been a success or not. And in fact, the knee replacement can continue to improve slowly for up to 12 months. So if you're one of those very unlucky people that is stiff and uncomfortable for the first period in the rehabilitation, don't give up hope, because it may be that it takes you 6 to 12 months for the knee replacement to fully settle down. So let's talk about activity after a knee replacement. We consider a knee replacement success when a golfer can get around a golf course. Now obviously not everyone plays golf. In fact, very few of our patients play this on a regular basis, but it gives you an idea of what level of activity we expect. You will not be able to play sport. Some people, their knee feels so normal that they do want to venture out and play racket sports and do normal activities, but the knee replacement is not really designed for those sorts of activities, and jarring and impact activities are really to be avoided. So you can use a cross trainer, you can get on a rowing machine, you can use an exercise bike, you can certainly swim, but we would advise front crawl and not breaststroke. In terms of tennis, doubles tennis is possible. Slow doubles tennis, social tennis, that is something that is possible. Equally, going skiing for a week or two is also possible on a knee replacement, but not hard skiing, gentle skiing. You certainly won't be able to run, and if you feel as though you can, you most certainly shouldn't run on your knee replacement. And this is one of the problems that we see in young individuals, where we're forced in patients who are in their 40s to go for a knee replacement because we have no other option available. And we've seen a much higher failure rate in this group as opposed to more sedentary patients, because if you make someone who's young and active pain-free, they tend to want to do active things, and that means that they tend to wear their joint out far quicker than if they were more sedentary. So what is the right age to have a knee replacement? The older you are, the better it is for us, because we only want to do this operation once. Of course you can have a second knee replacement. In fact, you can have a third, you can have a fourth. Each time we do the surgery it becomes more difficult and the results are less good. So you want your knee replacement to last you hopefully forever. Unlike hip replacements, if it's done in a sedentary individual, it may well last forever, literally. The revision rate, in other words, having to redo the surgery, is nothing like what we see for hip replacements, where they do tend to wear out over a 15 to 20 year period. We're not seeing that with the knee replacements when they've been done in people who are sedentary. So we like to do knee replacement surgery ideally in patients over the age of 65. Now when you're over 50, we're beginning to feel a little bit more comfortable about being forced down this route if we have no other options available. Anyone under the age of 50, it really has to be an exception, and it's only in exceptional circumstances that we would even consider this form of treatment. So what are the alternatives to knee replacement surgery? Well, the first thing is get over this problem about taking painkillers. Far too often we hear people in the UK saying, I don't like taking painkillers, I'm just not a pill taker. These tablets are sophisticated, they're there to relieve pain, they're safe, and if you can get by taking some basic analgesia or pain medication before you embark on a big operation, of course you should try pain relief. This comes in all sorts of different varieties. Some of them are good during the day, some are good during the night, and this is something that you need to work on with your GP. It may be you need to take a patch that gives you a slow release of the analgesia or pain relief over a prolonged period of time. It may be that you need to be on a small dose of a tablet that helps with sleep but also kills pain at night. Certainly something with paracetamol and has some form of codeine in it is something you should consider. And of course you should be taking anti-inflammatories if they're safe for you. And this is all something that I would strongly suggest that you discuss with your GP. So let's talk about injectables, because there are lots of things that we can inject to help your knee. The first is steroid. We've been doing this for a long time. This can be very effective at relieving an acute flare-up of pain. It tends to last on average between 8 and 12 weeks, and then the pain comes back. If you're in very poor health, this may be all that we have to offer, and we may keep you ticking over with a regular injection every 3 or 4 months, and we can safely do that 3 times a year at no risk to you. This is not something we would like to do on a regular basis for someone who's young and active, or younger and more active. And if you really have got to the point where you've tried a steroid injection and it hasn't really helped, it only helped for a short period of time, we probably wouldn't repeat it again. But it's certainly something that's worth considering. And I would have a steroid injection to try and settle my knee down before I'd consider a knee replacement. There are other injectables that we can also consider. There's the so-called hyaluronic acids. These are naturally occurring substances that we get within our joint. It's like lubricating the joint with oil. And we could try this, or perhaps 1 or 2 of these injections before again we consider the knee replacement. And there are newer things that you might want to look up online, slightly untested. Certainly the evidence is not there yet to suggest that we do this as a regular treatment, but platelet-rich plasma, where we take your blood, we take away the blood cells, and that just leaves us with the goodies, the plasma, and injecting that into the joint can relieve symptoms. There are certain tablets that are worth considering. People say, should I take glucosamine? It's certainly worth trying this. The evidence is not great that it helps, but it certainly does help in a proportion of patients. So the question is, how do I know if it's working? Well, you take the tablets for a minimum of 6 weeks. If you're seeing a significant benefit in your symptoms, then of course you continue to take these tablets. If, however, you're not sure, if you stop at 6 weeks and you see no reduction in your pain, then it's not worth continuing. If your pain becomes worse once more, then of course get back on the glucosamine. There are other procedures other than a total knee replacement that you may be suitable for. One is osteotomy surgery, where we realign the knee, and this is something that you will certainly want to discuss with us in Basingstoke, as we do a lot of osteotomy surgery. And in active, really it's the younger patients, we tend to consider this, where we realign the knee and offload a damaged area and load up a good area of the knee. So that's another surgical option to consider. I've talked a lot about total knee replacement, and we may find that your knee is suitable for a partial knee replacement, and they certainly behave in a much more physiological and a much more natural way than the total knee replacements. And again, this is something that your surgeon will discuss with you. So let's talk about weight. Unfortunately, we all like to eat, and our population is getting larger all the time. The bigger we are, the more we're going to load our joint. And part of the problem, part of the reason why you've got a problem with your knee is perhaps you are overweight. This is something that's very difficult for you to discuss in a short consultation with either your GP or with your orthopaedic surgeon, but it's obvious. And it's very important that you work out ways to try and reduce your weight if you are overweight, because this will help reduce your pain. And also, if you're considering knee replacement surgery, make it much safer and make the knee replacement last a lot longer if you go down that route. Stair climbing is something that's important because frequently patients that have arthritis in their knees struggle to go up and down the stairs, and it may be that you're, as I've mentioned earlier, on all fours, literally crawling up the stairs. Once you've had your knee replacement, you may be able to go up and down completely normally, but it's likely you'll just feel a little unsteady. You'll just want to hold on a bit as you're going up and going down. So just to summarise, we do a lot of knee replacement surgery. We have a lot of very happy patients and we have some excellent outcomes. But we have this failure group. So pain is the main indication for this surgery, and if you're in severe pain, consider it. If your pain's manageable, you'd like to look at other options, or if you haven't tried pain relieving tablets, you must go down this route first. Think about a steroid injection. This is something that you should certainly consider prior to having a knee replacement. You can discuss this with your GP, or we'd be delighted to do this for you up at the hospital. When you come to see us, it's likely that your x-ray will show arthritis. Your GP will be referring you up to the hospital to discuss the possibilities of a knee replacement with a surgeon. You will be with us for 15 to 20 minutes. It's very easy in that 15 to 20 minutes to persuade the surgeon to do this operation. You really need to consider whether it's time for you to be referred up to have that chat. You need to do some research. Look at this resource and look at other resources on the internet to work out whether a knee replacement is a good option for you. I've touched so far on what you can expect to do. Don't expect a normal knee. Don't expect complete pain relief. It may be that that's how it feels, but the vast majority of patients continue to have some discomfort, some instability, and the knee just doesn't feel quite, as they put it, normal or right. So we really have to manage your expectations, and you have to get an understanding of what a knee replacement is likely to give you. Then you're much more likely to be in that happy group. We'd like to thank you for taking part in this program, and we hope you found it helpful. If you have any questions or comments on how it might be improved, we'd be grateful for your feedback. Your information will help us develop this program such that it becomes a better resource for patients.